This week we're moving into discussing the policies and practices that are governing our system for diagnosing and treating language speech disorders. A brief overview of the federal laws governing this. First of all, I want to say that we must adhere to policies. Our policies are there for a reason. There's a good reason for them, but ultimately you will be the clinician and the professional, and you will make oftentimes the final decision about whether or not a child qualifies for services and is eligible for services, whether it's under IDEA, Part B, Part C, or in your medical setting. So yes, the policies are there. They are guidelines, but clinical judgment is a factor, and you need to be able to use your clinical judgment to make the best decisions. The author states, Nelson states on page 88, that master clinicians understand policy, what motivated it, and how to comply with it, but they also know how to focus on the needs of children as the true center of service delivery decisions and to keep policy dictates in perspective so services are not controlled by paperwork that serves no clear purpose. I really want to drive this home because I see this all the time and various settings across the state, across the nation, that when you let the policies guide your decisions and not what is the best need for the child, you will miss children. You will misidentify, you will misdiagnose, and you won't be giving children the services that they need. And that can apply across settings. So always remember, you're the master clinician. And if you put the needs of your clients, students, children first, you will be doing the right thing and you will be in compliance with the policies. So, the policies. Initially in 1973-74, we had Section 504 Act, the Rehabilitation Act of 1973, and this is still enacted today. I mentioned in my About Me post that my mother was the Section 504 dyslexia coordinator for Louisiana because in 1992, I believe, 91 or 92, Louisiana was found to be in violation of Section 504 of not providing services because of dyslexic students. It's one of those court cases that the book discusses. Not that one specifically, but how the book cites court cases such as Brown versus Board of Education that we know ends up driving our laws and our policies because of the decisions the courts make. So a parent basically sued the state saying you're not meeting the needs of my dyslexic child, and the court sided with the parent and said Louisiana was not, so therefore Louisiana established 504 coordinators in every school district in the state of Louisiana. And the reason 504 is there is because it gives access to accommodations, but it doesn't have the full protections of IDEA, and we'll get into that a little bit more. But 504 was the first step towards having access to services for students with disabilities. Next came the Education for All Handicapped Children Act, EAHCA. I've never known it by this acronym because it was enacted in 75, 76, and by 97, 90, it turned into IDEA, and that's how I've always known the laws that are governing our policies. Initially, we had Part B, which provided services for children birth 3 to 21, and then they enacted Part C 10 years later for birth to 3-year-olds so that they could have access to early intervening services. Then we moved into the Individuals with Disability Education Act, or IDEA, and that was in 1989-90. And IDEA has gone through two transitions since then. We have IDEA 97, which was in effect when I was in graduate school and when I worked in Louisiana. And then we also have IDEA 04, which was enacted by the time I came to Mississippi. We were still operating on IDEA 97, and that was in 2005. And IDEA 04 policies were enacted in 2009 in our state. And the book kind of explains why there was that delay from 04 of the law passage to the actual enactment, and a lot of that had to do with the adoption of the policies. And I skipped ahead to IDEA 04 before discussing No Child Left Behind of 2001. NCLB. I'm sure many of you are familiar with that and have heard it as you've been educated growing up through school and had to take this state test, MCT2 and SATP, all results of NCLB, Act of 2001. So Section 504, a general overview, it's still in effect. It has equal protections and rights for individuals with disabilities in any federal program, but the big difference between 504 and IDEA is that there is no funding for services. So basically it says, yes, you have a problem. Yes, you have a right to access services to help with your problem, but we're not going to give you any money for it. So in general, the best things that students have access to through Section 504 is accommodations. And this can be fluid, much like anything else. For instance, someone's used the example in the past of a child who is right-handed and they break their arm playing a sport. They're in the 9th grade, and so they have their right hand in a cast, and they can't write anymore because of their handbrake. So they can get Section 504 accommodations to have another individual write for them on the test or bevel in their answers on the test because they're unable to do it at that time. So that's an example of a Section 504 accommodation. But oftentimes you hear dyslexia and 504 associated together because the nature of dyslexia being that they usually have a high IQ and there's a discrepancy between their reading ability and their IQ level. To be eligible for a specific learning disability, the dyslexia is included in that policy language. I'll show you the policies in a minute. So that is included in that language, but usually they don't score low enough because of their IQ to qualify for IDEA. Their adverse impact is not significant enough. So therefore they can get Section 504 accommodations such as tests read aloud and extended time. And you hear a lot about 504 when these students get to high school and they have to take the ACT, a time test, and students with ADHD who may not be eligible for IDEA because it's not that adversely impacting their performance may be able to receive 504 accommodations for extended time on testing. But the key component here too is that Section 504 cannot have a disability that falls under IDEA. So if they would be eligible under other health impairment in IDEA with their diagnosis of ADHD, that's where they would fall. Okay, so I have here the Mississippi Department of Education policies. Let me get back to the PowerPoint. Okay, so I'll show you that in a second. First, let me discuss IDEA. So this ensures access to education for children with disabilities. Every child essentially has a right to free and appropriate public education, or FAPE for short. And I include all these acronyms in there because if you go into the schools, you hear about FAPE, LRE, and IEPs. They'll just roll off your tongue fluidly because these are frequently used acronyms. But the FAPE acronym, Free and Appropriate Public Education, essentially establishes that any child with a disability has the right to FAPE, no matter what their disability is. And that was revolutionary when it was initially established in the 70s. Prior to 75, anybody who had a disability, including language speech, was expected to do the same things as everybody else without any services for support. And the least restrictive environment component of FAPE was established in the revision in the 97 IDEA revision established the least restrictive environment component, essentially saying that we need to keep these students in general education. We need to hold them to the general education standards, because what was happening before 97, back when I was in school in the mid to late 80s, early 90s, is that if they had a disability, they weren't necessarily expected to perform on state tests or state exit exams, and subsequently they weren't getting high school diplomas, even if they had the ability to get a high school diploma, particularly with some accommodations or even modifications to the curriculum. So LRE introduced that concept of inclusion that we know so well today as implemented in special education services. Then the Individualized Education Plan, or IEP for short, is the individualized program for those students. Every IEP is different and individualized to students' needs based on their eligibility. IDEA is funded by Title I funds. Those are federal funds. So the federal government gives Mississippi the funds, and Mississippi has a formula or calculation to determine how much funds each district gives, and subsequently they disperse those funds to the district. And the district is allowed to spend those funds how they want to. And those funds go to paying for teachers, they go to paying for supplies and any equipment needs and various components of the implementation of IDEA. So the purpose is for students to have access to a free, appropriate public education. They have Part A, Part B, Part C, and Part D. Part A includes definitions and general provisions. And let me show you. This is the Mississippi Department of Education state policies regarding children with disabilities under the Individuals with Disabilities Education Act, Amendments of 04, or IDEA, also known as State Board Policy, or SBP 7219. And now it says effective September 15, 2013, because they just recently made some revisions this school year. Okay, so if we scroll down, we can find the table of contents, and we have Subpart A, General. And in this document, that's not what I wanted to do. In this document, if you did a search and find, for speech language pathologist, you will find where on page 50 a speech language pathologist was identified by our State Department to be the person who provides speech language pathology services. And it talks about what our description is: identification of children with speech or language impairments, diagnosis, referral for medical information, provision of speech language, counseling of parents. This is the same in every state, no matter where you go. It's the federal guidelines. The blue is what our State Department of Education added to make the language specific to our state. Okay. Return to page. Okay. Part A, general definitions. All right, Subpart B, state eligibility. That's not the eligibility is specific to our state, but it is talking about the FAPE, free and appropriate public education, limitations of FAPE, and implementation of IEPs. Part C is guidelines for early intervention services. I'm sorry, that's not in our state policies. But Part C you would find in a different place because it's a different federal policy. And that would be for early intervention services, the provision of the IFSPs, or individualized family service plans, that are enacted for students receiving services birth to 3 years old. This does talk about the Part B to Part C transition. Let's see if I can find that in and it talks about when you should start the transition. Some districts choose to serve students prior to the turning age 3, and some districts, here we go, transition IDA from Part C to Part B preschool program. So districts are allowed to start serving students anytime when they're age 2, but some districts choose to not serve students until they turn age 3. But the provision of services, the school district is responsible for evaluating whether or not a child is eligible under the State Department of Education standards for Part B eligibility if they have received Part C, the IFSP, prior to their school age. right. Part A, Part B, Part C, early intervention, and Part D includes provisions for supporting research, personnel preparation, technical assistance support, and dissemination of information. And I've never even seen those documents, but I would assume that would be a university or federal programs. There are lots of federal programs out there and federal grants that universities and other different facilities can receive to research implementation of early intervention services. So the least restrictive environment requirements of Part B include the notion that whenever appropriate, children with disabilities must be educated with children without disabilities. That's the socialization component. They need to be educated in regular education. Big difference in Part in IDEA 04 is that there must be consideration whether the child has had appropriate instruction in reading. So let me go back to this document. I'm going to scroll down. Okay, so there was a component in the new IDEA 04 about there must be consideration of whether or not the child has had adequate instruction in reading prior to ruling them with a disability, but this was only specific for specific learning disability. And that is essentially the philosophy of RTI. Now, I talked about earlier that the black is the federal regulations. The blue is what our state inserted itself. So if you get down here to page 290, 289 on the page numbers, but 290 on Adobe, Special Education Eligibility Determination Guidelines. And this is the driving force for every eligibility that falls under IDEA 04. We'll come back to that in just a second. So we have to consider early intervening services. That essentially is the RTI's components of the services. Another addition to IDEA 04 was that Part B, special education funds, allowed for no more than 15% of special ed funds to be used in general education services. Some states across the nation use these for funding for SLPs, possibly participating in RTI services. However, our State Department has been very clear that SLPs are strictly funded through special education funds. That has to do with a law in our legislature and on our state law. And it's not just SLPs, but anybody through special education. So therefore, SLP's roles in RTI is limited in Mississippi. So the book talks about we can be very involved in RTI to the point of even giving services to students who do not have special education rulings. But I want to be very clear that in Mississippi, that is not the case. Okay. Now, the next section talks about the No Child Left Behind, but before we go there, there's the disability categories. So every state, no matter where they are, have these 12 disability categories. In the book, the first one talks about mental retardation, but now our state, and in general most of the nation, has adopted the term of intellectual disability because of the negative connotations to mental retardation. So you have the eligibilities of intellectual disability, or ID, hearing impairment, HI, speech or language impairment, and in our state is language speech impairment, so it's LS, visual impairment, VI, emotional disturbance, ED, orthopedic impairment, OI, autism, AU, traumatic brain injury, TBI, other health impairment, OHI, specific learning disability, SLD, this is the one that requires RTI, deaf blindness, DB, and multiple disabilities. Revisiting the policies, all right, you have your general guidelines. And then you have the disability category. So here's the definition of autism. And these are all the components that must be included in the evaluation of a child who's suspected of having an autism eligibility. Here is the deaf-blind category, developmentally delayed, which was not listed in the book, I'm just noticing, but developmentally delayed, major category for children who need special education services. Most of our children are falling in this category when they're in early intervening services, age 3, 4, 5, 6, all the way up until age 10. By age 10, So it says birth through 9. So before they turn 10, they must be ruled into a disability category that's other than developmental delay. But this is a good category when you really don't know what the child's deficits are. They may be autism spectrum disorder, but it's too early to tell. They may just have a specific learning disability. They may have significant cognitive and language deficits, largely due to their exposure and environmental factors, but their deficits are so severe that they need the support services of early intervention. So to be DD, though, you cannot have any of the other 11 categories except for language speech. And the big caveat with DD in Mississippi is that a child cannot be developmentally delayed and have an eligibility of language, but they can receive services as part of a related services. So a related service is when a child has an eligibility of one as a primary disorder, such as DD, or specific learning disability, SLD, but receive services from the SLP as support. SLPs, occupational therapists, physical therapists all fall under the related service category. All right, we have emotional disability. Those are your children who might be bipolar, have severe emotional disturbance, but this also requires information about positive behavior systems. I've talked about PBIS, or positive behavior systems, previously and in some of our discussions, and that comes into play with these emotional disturbances. These are your behavior problems, kids who cause a lot of problems with their behaviors that are inappropriate. And we have a student now who's been to mental health facilities several times because he's demonstrating behaviors of tantrums and physically harming other students, physically harming the teacher, and possibly pre-schizophrenic, for lack of a better term, which is very sad to see in a child that's 7, 8 years old, but completely possible. So he's a developmentally delayed child right now because you don't want to put a ruling of emotional disturbance on a child who's 6. That's such a significant disability that's going to follow them for the rest of their lives. They can't even graduate with high school with a regular diploma because of that diagnosis. So a lot of consideration must be given when you're considering this diagnosis. Hearing impairment, that's fairly standard. Intellectual disability, formerly known as mental retardation. Language speech impairment. Here you have the definition of language speech. You have the ASHA reference about the components for communication disorders. Articulation phonological processing disorder would be 1. Fluency disorder would be a 2nd. Voice disorder a 3rd. And language disorder a 4th. And it's important to note that in the language disorder category, discusses form, content, and function of language, much as we discussed in our chapter 2. And phonology, morphology, syntax, semantics, or pragmatics. All of these categories contribute to the language disorder category. So you can have a language disorder eligibility in any of these subcategories. You don't have to have that overall test score for language disorder. You can use subtest scores or supplemental tests that measure just one component, such as syntax or morphosyntax. This discusses the evaluation requirements of language speech. Of course, you have to have a hearing screening, results of an oral facial exam for articulation disorders and voice disorders. If a voice eligibility is considered, you have to have a statement of release and recommendations for services from a physician, basically a physical exam. For disfluencies, you need to have the number, types, and severity of disruptions, description of secondary characteristics included in a fluency evaluation. And then for language disordered assessments, you have to have results of standardized measure of language, and the score must be at least 1.5 standard deviations below the mean of the test in the areas of expressive language and or receptive language, including those 5 subcategories. When articulation evaluation has completed for children aged 30 months or older, you want to have evidence that children's articulation skills are below an age-appropriate peers. So anything standardized measure or norm-based measure that says their articulation is below the average range for that age. And how the communication adversely affects educational performance. social performance or vocational performance. That's very critical because you can meet the standardized scores but not have the adverse effect. And the documentation of the child's speech language skills and conversational speech. The category of multiple disabilities, which means you have more than one disability. Two or more areas may exist in the following categories: deafblind, SLD, developmental delay, or language speech. They don't constitute multiple disabilities in and of themselves. Language speech, along with another disability, is generally viewed as a secondary condition, not a multiple disability. So you couldn't be ADHD and language speech to be considered a multiple disability. You would have to have more than one significant physical disability. And these all are at the diagnosis of a physician usually. And they cannot fit appropriately into any of the other 11 categories. Orthopedic impairment, that would be children who have orthopedic clubfoot, abscess of one or more members, bone tuberculosis, so really physical things here. Cerebral palsy falls under orthopedic impairment. Other health impairment is a specific diagnosis from a physician that doesn't fit into one of the other categories, including ADD, ADHD, diabetes, epilepsy, heart condition. We've had a multiple sclerosis, muscular dystrophy child before, so he fell into this category. Usually your syndromes fall into this category. Tourette syndrome. Specific learning disability, and I wanted to bring us to here because it has the pre-referral requirements. And you have to have documentation the child was provided appropriate instruction and general education services delivered by qualified personnel. And we have database documentation of repeated assessments of achievement at reasonable intervals, which is essentially progress monitoring. We're testing them every week, every 2 weeks on the same skill to measure their progress and see if they are growing. And this talks about the evaluation requirements, response to intervention, RTI, and then the other methods for SLD. And they can qualify for SLD in any of these categories: oral expression, listening comp, reading, written expression, basic reading, reading fluency, reading comp, math calculation, math problem solving. Oftentimes, oral expression and listening comprehension, you can have a language disorder child who turns into an SLD child in these areas of oral expression or listening comprehension because the disability becomes so significant. We'll discuss that a little bit later in the chapter. Traumatic brain injury, that's pretty cut and dry. If they have a TBI, they can qualify in that area. And then visually impaired, a significant visual impairment. So those are our state eligibility guidelines, which I will post for you. Okay, moving on to No Child Left Behind. It is the accountability law, and this established the adequate yearly progress standards that a school district must make adequate yearly progress. The goal of No Child Left Behind, it was passed in 2001. The goal was in 12 years, essentially the school year of 2013-2014, every child would read at or above grade level. Well, that was too optimistic. That was just too high of a goal to reach because every child's not going to read at or above grade level because every child's not the same. And you have disabilities, and you have learning deficits, and you have the incredible achievement gaps between students of various cultural, linguistic, and socioeconomic backgrounds. So when you're finding all those factors, it's very difficult to make that sort of change in a 12-year period. I will say that most states, including our own, have been lifted from the No Child Left Behind compliance because, as the chapter points out early on, these things are governed by the politics that are happening in the nation. No Child Left Behind was the previous presidential administration's initiative, and the current presidential administration has education initiatives that are different than NCLB, so therefore they are giving waivers to many states if the state applies to be waived of the No Child Left Behind accountabilities. So our state received the waiver because we implemented a valid teacher evaluation system called MSTAR, and then we're using that to evaluate how our teachers are adequately instructing students. So we're still discussing NCLB, but really it is essentially the components of the growth components are gone from our state and many others. In addition to that, we've also moved on to Common Core state standards and the assessment tied to the Common Core state standards. So that's going to change the accountabilities too. But it did state that 15% of SPED funds could be used on general education, and that is where the SLP's roles would come into play many times in other states. It also established that methods for teaching reading must include the 5 essential components of reading: phonological awareness, phonics, fluency, comprehension, and vocabulary. Of course, phonological awareness we've discussed already. You did the little quiz and did great on it. Phonics, the letter-sound correspondence. Graphing, orthographic knowledge. The graphemes being the letters and the knowing the sounds they represent. Fluency is how fluently they're able to read passages. Often measures done how many words in a minute are they expected to be able to read. Comprehension, of course, is a big component of what we do, as well as to how they're understanding what they're reading. If they are not fluent, they're not going to comprehend what they're reading if they still have to decode words individually, piece by piece, and struggling with the phonics component. So these are all tied together, much like the circular ties we've talked about throughout these chapters. And then finally, vocabulary, not just their expressive vocabulary of what they're able to produce, but their comprehension vocabulary, the academic vocabulary component, and the ability to be able to teach vocabulary, because we as SLPs know how to teach vocabulary, but oftentimes vocabulary has been taught traditionally as you give a word and you're asked to look up the definition in the dictionary, and then you're tested on a test, multiple choice format of what does this word mean? What is a synonym for this word? So vocabulary is a key component to reading. And this was all a result of the National Reading Panel's study of effective reading instruction. So I've posted a new discussion thread, and I want you to go back and visit that regarding how were you taught reading? Were you a child of the 80s like me, 90s, 70s? When you were in school and learning to read is probably affecting how you learn to read in your reading, decoding, word-to-text skills even today. And then if schools were found not to meet their adequate yearly progress, they were put into a corrective action plan, meaning they needed to be on a plan of improvement. No Child Left Behind also mandated that 95% of students must be tested, including your children with disabilities. And there's only 3% of the population with disabilities was allowed to take the alternate assessment. So these would be your most significant cognitive deficits. Those were the ones that are allowed to take alternate assessments and not participate in the statewide testing measures for AYP. Okay, so moving into assessment and intervention processes. So when we're looking at students and testing, we have a variety of things we must consider. But first, the author states on page 92 at the bottom, intervention is more likely to be successful when it's comprehensive, intersystematic, and contextualized. And second, the more intervention teams know about language and literacy, the better prepared they are to make a difference. That's driving our assessment intervention process. So we have the diagnostic information, that component. Those are our standardized tests, the scores that we are yielded, and in addition to all the other information that you're gathering through the standardized testing process. Not standardized testing alone, but that is a critical component of the diagnostic information. Then you have developmental information, usually criterion reference tools that identify gaps between functional levels and expected levels in relevant domains. So just your basic norms. A big example is the articulation eligibility in our state requirements about they must have something that's below the average range of the normal performance for those articulation sounds. A 3-year-old who doesn't do S-blends isn't a 3-year-old who's going to be eligible for articulation services because that's average in the average range for 3-year-olds. And then contextualized performance information. These are curriculum-based assessments. How are they performing in the curriculum, meaning the expectations, the standard the curriculum in school is asking them to do. But all of these assessment processes must be reciprocal, ongoing, and recursive. Now, of course, you're not going to continue to redo standardized testing because that would affect the validity of the test. But a criterion reference tool, a curriculum-based measure, you can give periodically to measure their growth and gain in skills, and you can also use that to drive your instructional strategies and interventions. So we have, in our service delivery, we have collaborative models. These are team models, and it must be a team effort is needed to mobilize systematic factors to foster a child's development. So the book discusses the 3 models of teams: the multidisciplinary team, interdisciplinary team, and transdisciplinary team. In our State Department policies and the federal policies, our team that makes eligibility decisions is referred to as the multidisciplinary evaluation team. There are components of that team of members who are required, including the regular education teacher for children who are school age, the parent, and administrative representative who can assure that the budget will be provided to provide services if the child's eligible, and then one person who has the diagnostic understanding for evaluation. So if it's a child, SLP falls under that category, but also your psychologist, school psychologist, or psychometrist who does the psychometric testing components. So interdisciplinary and transdisciplinary teams, well, great. That's not going to be the technical term in schools and most of your other settings, but just because they're not technically called transdisciplinary or interdisciplinary doesn't mean they can't function in that form. But we are called multidisciplinary evaluation teams, and usually that's how we're implementing services. Everybody acts in isolation. The teacher does a teacher narrative to identify the strengths and weaknesses of the student. The SLP does a language speech assessment to identify that student's language speech skills. And then the psychometrist does the psychometric testing of achievement levels and IQ levels. And the social worker or case manager interviews the parent and gets the parent input. All of these happen separate, and then the team comes together, discusses all of the results, and makes the evaluation. That is the standard for schools, but there are definitely other schools systems that do it differently and work collaboratively and together. And you probably work much more together at the university level as a team than when you parse out into the world and have different departments with different functions. Okay, so let's move into the clinical questions. I divided the clinical questions into 2 parts, the testing part and the IEP part. So clinical services begin with screening or referral, and when services are justified, they're implemented with recursive stages of planning, implementing, and evaluating progress. So your first question is, does the child have a problem that might signify a language disorder? This is the screening or referral process. Teachers can refer, parents can refer, anybody can refer for a screening. If a formal screening is done, parents must give permission for their child to be screened. So the good thing to keep in mind, if you pull out a box, you need parental permission for testing and to get their consent for that testing. But you can do informal screening with students in their environment, naturalistic setting, classroom setting, without getting parental permission. The state also has a new law effective this year that all first graders must be screened for language, speech, fluency, and voice deficits. So there wouldn't be any need for parental permission for that screening because now it's mandated by the state. And if you do it with everybody, there's no need for permission. Hearing screening also falls in that category because we screen hearing and all of first graders and all of fourth graders in my district. That varies across districts, but first and fourth grade are the state mandates. So if you do it with everybody, then you don't have parental permission needed. But the first question, does the child have a problem? That's your screening referral process. Second question, does language difference explain all or part of perceived gaps in a child's current abilities? We've talked frequently about the socioeconomic and culturally and linguistically diverse backgrounds that students are coming from and not necessarily prepared for that academic environment. So you can use a dynamic instruction or a dynamic assessment approach to determine whether or not this is truly a disorder or is it just a difference. Dynamic assessment would be where you select a skill, maybe based on a curriculum-based assessment. It can be as simple as, does the child identify position words appropriately? You target the skill for 2 to 4 weeks, 2 to 3 times a week, much like you would do a traditional therapy model in the classroom. The classroom teacher is the one instructing the students on this. The classroom teacher would use multisensory strategies such as using manipulatives to teach the child the task. And if the child is able to master the skill or show growth in that short time period, then more than likely they're not a child who needs a language assessment. It's more of a language difference, not knowing the academic vocabulary. And a lot of these deficits that you'll see are related to vocabulary and narrative ability. So teaching a child how to tell a story is another example of dynamic instruction. And we'll discuss this a little bit further later on. We'll just touch on this right now. So if the dynamic assessment or dynamic instruction yields that the child's not learning and growing, you can move to question 3. Or sometimes you can skip the dynamic instruction assessment if it's very evident the child has a significant language problem. And you can tell the significant language problems from the bubble kids that you're not really sure if it's difference versus disorder. The significant language problems, they have short syntactic structure, speak in short sentences, very low vocabulary and semantic skills. They're the kid who walks up to you and you say, "What's your name?" He goes, "Name? Who's your teacher?" "Teacher." They're very echolalic and repetitive in their speech. Are you a boy? Boy. Are you a girl? Girl. You can't have any conversation with them. They don't understand question language. Those are very obvious deficits. That if that's an example of a 5-year-old kindergartner. If they come to you doing that, then there's a significant issue there. You don't have to do any dynamic assessment. 3, does the child have a language disorder? This is your testing process. So this is where the testing comes into place, and you get the parental permission for testing. You must give them their rights, which are called procedural safeguards. And I know you will discuss this more in another class. You'll discuss it whenever you go off campus to your school clinical practicum, but I want to touch on these for you. We'll get into the types of testing, how do you drive your testing process in a little while. But under IDEA 04, part of this process, you have to have consideration whether the student has had adequate, appropriate instruction in reading, but that is only for SLD, specific learning disabilities. If anybody tells you you have to have RTI data for language or anything else, that is not an accurate statement. When I first moved to Mississippi, they did make us do language interventions for students with language deficits before we could even test. And it was not appropriate, and the State Department changed that policy. So you can move straight to testing if a child has a significant language deficit that is evident. Then we have the 2 questions in 4. Does the child qualify for special services? Does the child need special services? So qualifying, yes, they hit that standardized score. They're 1.5 standard deviations below the mean. But do they need special services? That is where the adverse impact on educational, vocational, or social skills come into play. If you do not have an adverse impact, then they are not eligible. They don't need special education services. Your children who have significant cognitive deficits or maybe intellectual disabilities will also have significant language deficits on standardized testing. But if their language is functional in their environments and appropriate, then they're not necessarily eligible for services. They don't need the services, particularly if the services can be addressed by the other special education teacher. Now, that's not to say that you can say for every single child who has a low IQ, no, you don't qualify because your language is commensurate with your IQ level. ASHA is very clear on that, and there have been case studies or court cases where you would be cited, essentially, and get into trouble if you said the child did not qualify based on their overall cognitive ability. Studies show that the children's language abilities can surpass their cognitive ability. This is that self-fulfilling prophecy the chapter talks about later on. So you need to make evidence-based decisions based on your clinical judgment and the impact the students' abilities have in their education or their vocational performance or their social skills. Okay, so once they're eligible, now we move into the IEP stage, and I have our State Department of Education IEP for you. Number 1, what are the child's levels of performance? This is called the present levels of performance. Here is the Mississippi Individualized Education Program, or IEP. It's being revised right now, so by the time you get in schools, it's going to look different. But I could show you what it looks like right now. All right, so we have 6 questions for the Performance and Current Educational Program, Present Levels of Performance, PLB. How the student's disability affects involvement and progress in general curriculum. So we can say, John's language deficit interferes with his ability to answer questions appropriately, follow multi-step directions in the classroom, understand classroom vocabulary, etc., etc., etc. Then you can move on to number 2. Detailed description of students' current performance in reading and math. Oftentimes we'll use universal screeners, a screener that's given to the entire school. Our school uses DIBELS, reading, read, below benchmark, and DIBELS math scores, and the read below benchmark as well. But we would be specific about how those scores were in comparison to the rest of their peers. 3, results of the initial or most recent evaluation of the students. This would be your eligibility. Results of the preschool language scale 5 indicated they had a standard score of 75, which is the 6th percentile. 94% of the students do better than this child, and a significant language problem. 4, strengths of the student, what the student is able to do. You can use things for the teacher narrative. The student has good skills and motor skills, general physical skills, social skills even. Concerns of the parent, and that would just be where you ask the parent, what are your concerns for enhancing the education of your child? And 6, description of the student's social behavior or emotional skills. All right. Number 6, what services, including assistive technology, does the child need? I have here special considerations, because if you move down to page W5, most of these are already included on the IEP. So consideration of special factors. For a language speech child, you would check language communication needs because the child has those deficits. Seven, should specific context be changed or introduced? So these would be service delivery options on the IEP. You would include this in the accommodations modifications page. What things do you need to do differently to accommodate the child in the classroom? Where, frequency, how often are you doing it? Physical location, is it regular education, special education? Anytime the child is not in general education, why they're not there? And why are they not with their peers? All right. Number 8, which speech, language, literacy, and communication abilities should be targeted intervention? These are your goals and objectives. So this is the page we often use the measurable annual goal. The child will master the language benchmarks, or it would be Common Core State Standards for language, for example, with 80% accuracy at the first grade level. And you can list those specific skills from the Common Core the child needs, such as the multiple uses of words or distinguishing opposites or antonyms. You could also use this page where you would just do one annual goal. The child will increase intelligibility to 90%, 95%, but you wouldn't have any specific short-term goals. Here, if you want to increase intelligibility, you could list specific sound errors that you want to target. But you can't do that on this page. But those are your goal pages. All right. What intervention, approach, and activities should be used? This is your theory that's driving your intervention and approach. This is not going to be listed on the IEP because that could change depending on what the student's presenting with. And as the discussion from last week showed, we'll use different interventions and approaches based on what the child is presenting with. So you're not going to put that in writing on the IEP because that's a legally binding document. But say, for instance, you want to use the DeBart Association method with a student with severe phonological awareness and phonetic deficits, then that might be the intervention or approach that you use. 10 is progress occurring, so that would be your progress report. You could go back down here to where we had the language communication needs, and you report their progress. This is when you report it. Oops. And this is where you report on the goal sheet. You have the number of correspondence for the reports of progress over different periods. 1, 2, 3, or 4. How much mastery do they have? Do we anticipate them meeting their long-term goal? If we don't, the reason why not. So you have to report that progress to the parents about how the child is gaining on their objectives. If enough change occurred that's time to add complexity or to target a higher developmental level. So this would be changing the goals or objectives. And if that is the case, then you need to do a new IEP. If not enough changes occurring, what modifications are needed? And that could be also changes in IEP, but it could just be changing your methodology. All right. Does the current service delivery model remain best for meeting the child's needs? And I love the table 4.2 on page 99 that talks about the various service delivery options. I'm a big proponent of push-in therapy, of working in that classroom with the student. And you can even pull other students with those deficits into your small group instruction. But it just doesn't always work out that way. Sometimes it's difficult to go into the classroom during their small group instruction. Depends on the teacher, depends on the grade level. But I've used small group instruction push-in oftentimes in my therapeutic career to target skills that are related to the curriculum. You have collaborative consultative modes where you're collaborating with the teacher. You have co-teaching where you team teach a lesson with the teacher or split the class into groups to teach the same lesson but at different levels. You have your traditional pull-out context, small group or individual. You can have different settings where you're doing it in the home or on the playground for social contexts. You also have parent or teacher implemented interventions which would move the child into the consult monitoring stage. So, and then your schedules, you don't have to have everything 2 times a week for 30 minutes. It can be very variable based on what the child needs. I'm a big proponent of block schedules. It talks about the 3-1 schedule under block schedules, but we could do 3-1 in that. You can do, if you have a work week, 4 days a week you do therapy, and the 5th day you set aside for testing, screening, and IEPs. So that would be implementation of the 3-1 model on the weekly schedules. But our State Department's really not a big proponent of a 3-1 where you do 3 weeks of services to students and 1 week of consultative and indirect services. But I do like that block of that you set aside times to work with that particular grade level. And then finally, does follow-up monitoring indicate a need for additional services? I'm sorry, I skipped number 14. 14, is it time for the child to exit formal intervention services? And in the near future, we will have a dismissal criteria recommendation from the State Department that says whether or not the child is eligible for dismissal. Of course, if they've met their standards and their goals, they're ready for dismissal. But there could be variations in that due to lack of progress or need to be dismissed, or say if you have a language kid who is also receiving SLD services, maybe the SLD teacher is the appropriate person to continue those language services and they transition into that, because you can't always resolve and fix the language problem. It's more than likely always going to be there if it's a true language disorder, but that doesn't mean they always need services. It's our job to remediate and train them compensatory strategies for support. It's not our job to completely fix it so that the problems resolved, and they turn from a language disorder child into a typical language child. It's not going to happen. So if they do get dismissed, does follow-up monitoring indicate a need for additional services? So sometimes they might need to continue the process along the way, and you can continue your consultative role. But I do want you to remember that in the summary it says decision points are guided both by policy and best practice concerns. We have to keep best practice in mind, including the policy, because sometimes the policies aren't going to always make the best decisions for the child. Okay, so moving into categorization, diagnosis, and causation. Categories, they can be good and bad. Obviously, as she talks about the pros and cons, we know that we're heterogeneous and we don't all look the same. We're all individuals, so the lines are going to be blurry on those edges of categories. So unfortunately, the categories might be blurry, but they are necessary for eligibility decisions. But they may not always be appropriate. They may have a lack of recognition of the complexity of human differences. They may be unnecessary stigmatization, and they may not have enough benefits to overshadow the limitations. And autism spectrum disorder seems to fit into this for me very well, as far as it's difficult to categorize it because it's a spectrum. There's a high end and there's a low end. There's a lot of variation in between, and no two children look the same or act the same. So that variance is something that we need to be considerate of. But a primary goal of contextualized intervention, everything context-based, as this book is discussing, is that children interact to reduce functional limitations and increase opportunities to participate, thus reducing disability, which is consistent with the World Health Organization definitions. And the categorization is necessary for them to access certain services, such as benefits from Social Security, the special education services, and eligibility categories. So policy requirements make it necessary to categorize them to find them eligible for services and receive the treatment. Primary sources for categorization, for definitions, there's the World Health Organization International Classification of Functioning, but we really don't use that very much in the United States because we have the Diagnostic and Statistical Manual of Mental Disorders. The book discusses 4, but 5 is now. So 5 is the most relevant, and 5 changed the definition of autism, Asperger's, and Rett's all into one definition of ASD, autism spectrum disorders. So that's very well worth your time to get a copy of the DSM-5 and review it, because there were some significant changes. When it comes to the categorizations, it talks about some groups work within national, state, and local boundaries to identify children with disabilities and related conditions and set policies and criteria for finding children eligible for special ed services, group advocacies. And I wanted to point out that MISHA, the Mississippi Speech and Hearing Association, was very actively involved in the criteria and eligibility definitions of the State Department policies from IDEA in 2004 that were both the IDEA 04 policies currently in effect, adopted by the State Department in 2009. Much of that information came from MISHA's work with the State Department of Education. So that is one role of our state organization, is to be an advocate for the students we serve and the clients we serve. And in the old eligibilities, you had to have a proof that the child had cognitive functioning ability to receive language services or articulation services. But that component was removed in the new policies because, as I stated before, that's not justification for a child not to receive services. They can benefit from those services in spite of their ability levels. If anything, it can greatly surpass it. So that's something to keep in mind when you get out into the working world and you wonder about the value of being a member of the state association, because you're probably well aware of what ASHA does for you, primarily being that you carry that certification no matter where you go, and it is the professional standard for SLPs. But in addition to that, the state organizations actively work for you in your state to make the services you provide the most effective that they can be. And then finally, on the individual level, clinicians are often responsible for diagnosing disorders, possibly as a prerequisite for determining eligibility for service. So you need to make the decisions based on the preponderance of the evidence. If you have a kid sitting on the bubble who has that standard score of 79 or 78, and the State Department guidelines say 1.5 standard deviations or 77, is not appropriate to say, oh, the child doesn't need services because he didn't hit 77, he got 79. If you have enough evidence to support that there is a disability there that's adversely impacting education, vocational, or social performance. And the same goes for that example that we used in the first discussion about did the district make the right decision based on the screener. The screener is using arbitrary cut scores to determine whether or not a child is at risk or possibly needs further evaluation for a developmental disability. That's not an appropriate method to use, though, because that cut score is not always accurate, as we'll talk about in a few minutes, and the preponderance of the evidence, just through conversational experience from the child, indicated that he needed more services than what he was eligible for based on the results of that screener. So always keep in mind it's the preponderance of the evidence. You can have a general language, take a general language test like the Self 4 or Self 5 that gives you a standard score based on these 4 or 5 subtests. So that you get the standard score of 79. But if you look at the receptive language subtest score or the expressive language core score, you can see that that score is falling into the 75 or 70 or 65 standard score range. So the preponderance of evidence there supports the need for eligibility. They don't have to have 1.5 on the composite core language score. It can be 1.5 standard deviations on any of those 5 subcategories. So you have a standard score of the core language of a PLS or a self or a TOLD, but you note the deficits in morphosyntactic skills. So you give a test geared towards measuring morphosyntax, such as the Rice-Wechsler test of grammatical impairment or a SPELT, and then the child is eligible for the services based on the scores from those supplemental tests. So preponderance of the evidence. Don't let the policies dictate whether or not a child is eligible. You as the clinician are the ultimate judge of that. Okay, so now into causation, because I have many conversations with parents. Well, what caused them to have this problem? And of course, we always say there's a variety of factors. So we know etiology is the causing factors for deficits or disorders, but this requires caution because we know just based on the theory that it doesn't seem to be one kind of dry theory that definitely governs how language is acquired and used. Everybody pretty much had 2 theories at least driving their theoretical base. So if there's 2 theories driving your base for your practice, more likely there's 2 etiologies for the possible problems a child is experiencing. So causes are layered. They use the peeling an onion example of that. You have the first layer and you peel that back. Oh, our environment was not great. But then tack that on with, I probably am a child with ADHD and I'm not paying much attention and I'm losing a lot of information in the process because of my ADHD. So it's layered as peeling an onion. Its causes are circular. They fall into circular cause and effect patterns in which timing of internal patterns of neurological growth move in and out of synchrony with advances in external demands, such as changing academic language expectations. So a child who's performing okay academically in kindergarten or first grade, when they get to 3rd or 4th grade, might have some language deficits presenting themselves because the changes in the demand for language has grown and become more complex. And then causes are multifactorial in that they have multiple factors influencing them, such as developmental disorders. And we know that there's a lot of comorbid conditions that can exist with language disorders, such as ADHD, or language disorders as a component of a larger disorder, such as autism spectrum disorders or specific learning disabilities. So it's multifactorial. Standardized testing. So there are many considerations to be given to standardized testing. It along with the categorization, essentially is a necessary evil. We know they're deficient. We know they're not the best thing to use, but we have to have some kind of standard for comparison across ages and populations. And so therefore the standardized testing is required. So you use this to compare it to a child's normative sample, other children the same age and the same cultural experiences, backgrounds. But we must have consideration of factors besides disorders that come into play when we're selecting our standardized test. Before we get into validity, it states test scores document discrepancies between what a particular child can demonstrate when attempting structured and controlled age-appropriate communication activities, and what a typically developing child can demonstrate when attempting the same task. So the key component of that is if they're structured and controlled activities. Sometimes you'll have the performance that's there in the structured and controlled task, a closed task essentially, but you get into an open task where there's more language demands on the student to answer a question and spontaneous knowledge, and it's very much more evident that there's a deficit there. So when considering standardized testing, we must first consider validity. We have the two different methods of validity. If a test is intended to diagnose language disorders, it should have construct validity and institute a valid. If the test is intended to diagnose language disorder, it should reflect the construct of language and sample enough content to constitute a valid assessment of the construct. So construct validity is the degree to which the test reflects expert opinion and current evidence on the nature of language and language disorders. Content validity is judged by the evidence of how well the content of the test matches its stated purpose. So content validity, the content of test. And construct validity is the degree of the nature of language and disorders, and the theory behind it. These are very traditional testing methods. In addition to that, you have the item response theory, because item response theory is essentially like the personal reflection. How do scores from 75% white kids, 3.6 Asian, 12% African American, 0.9% Native American sample apply to my 100% Cambodian child? So your population, there could be a population that you're serving that every single person in that population, every single child in that population is going to miss that item. So item response theory throws out that item that everybody misses because of their cultural linguistic background, and helps to better ascertain whether the child's truly a child with a deficit or just a language difference. But it's difficult to, if you're doing item response theory, you have to report any deviations and standardized measures. And I can tell you, as somebody who's tested kids for over 10 years, I can predict on a particular test, particularly a test I'm familiar with, if a child's going to miss an item or not, based on their cultural linguistic background and their SES status. But every child who misses that item isn't necessarily a child with a disorder. And if there were other items of that test that if they miss that, despite their background, they should have that general knowledge to be able to perform that task. A good example is plurals, plural usage in African American dialects, and often they're not marking those appropriately. But most of the tests do have cultural linguistic variations for you to consider, that you can give a child credit for their dialectical variation, even if they're not producing it appropriately. So that's along the lines of item response theory, the items that we allow to give them credit even though it's not what would be expected for standard American English. So Then there are different types of tests. We have the tests designed as comprehensive measures, and then we have the tests that are designed to provide more in-depth information in selected areas of concern, such as a morphosyntactic test, a semantics test, a pragmatics test, something that's very specific to those particular areas of deficit. And a good example here too is that an Asperger child might have been had very adequate, appropriate responses and language skills when it came to a standardized language assessment that measured core language, but their deficiencies came at the pragmatics of language. So that's why they were eligible to receive services under pragmatics if you give them a pragmatics test or some type of criterion reference measure of pragmatics. So after you consider the types of tests you're selecting, you need to consider a test sensitivity and specificity. And when you're considering this, sensitivity is how sensitive is the test to identifying the disorders, and how many false negatives that do you get. If you have a sensitivity rating of 80% or 0.80, that means 80% of the kids that you test that fall into the language disordered range are going to be truly children with language disorders based on clinical judgment across different clinicians and settings. So that still allows 20% of the kids that you test to get a false negative, that they might fall into that standard deviation or standard range of being below the norm, but not truly have a language disorder or deficit. So sensitivity, how well does it identify the language disorder? And then specificity, how specific in identifying typical language? How often does it put the kids with typical language as having the average typical language? Or do you have false positives in that they might have typical language, but they fall into that disorder category for some reason? Maybe they just have a bad day, or maybe they have cultural linguistic differences that puts them into that category. So test sensitivity and specificity. One of your required readings is cited in this paragraph, Spalding, Plant, and Farinella, 2006, talking about the natures of the test that we use, specifically our language test, and how many of our tests meet these sensitivity and specificity recommendations of 0.80 or greater. I mean, if we're 80% accurate in identifying, you still have that risk, a 20% risk that you're getting a false negative or false positive. We recently had a student that had qualified or was eligible from a different facility based on a language test that, in my opinion, did not have the sensitivity and specificity that I prefer when choosing my standardized testing measures. And then we go to evaluation and we test. And with the test that I selected that I felt had good sensitivity and specificity and was appropriate for his cultural linguistic background, SES status, and just general standardization population. And he fell into that 77 range. So he met the standard score qualification for State Department of Education qualification. However, I truly did not feel that it was a child with a language disorder because of the types of tasks that he could perform outside of the standardized sample, using other measures such as the test of narrative language for his narrative language ability, conversational speech analysis, general language functioning. But, you come to eligibility, and if that's a difficult concept for us as professionals to grasp as far as test selection and test sensitivity and specificity, it's very difficult to explain to a parent that although you get the score, he really doesn't qualify, because the policies and the guidelines state that he should qualify based on that score. So I would always say in that situation, err on the side of caution. It's better to treat something that's not really there and have great success, because it won't hurt us to provide our services. It does hurt us to not provide our services based on the inappropriate selection of measures, such as the cut scores. And the cut scores comes into play in that first example I used, with the preschooler at age 3 who on the screener didn't meet the cut score that was chosen, that I think was based on 24 months below his age range. So if he's 3, you're performing tasks that are at the 1 to 1.5, 2-year-old level. By that use of that arbitrary cut score, the child didn't fall into the range for further testing or for qualification, and the clinician stopped. But as you all noted in your discussion, that was not the appropriate decision to make, specifically based on the diagnosis the child received 2 years later. So we have to be very critical thinkers and planners when we're considering the standardized testing measures that we're using and how well they do their job of appropriately identifying disorders. And you always have that risk, even if you choose the most sensitive or most specific test. If it's at the 8.8 level, you still have a 20% risk that that child's going to fall into the false negative or false positive range. So nothing's perfect. And again, it goes back to the preponderance of the evidence. I like the statement on page 110 that sometimes teams may be willing to risk a certain type of error to achieve a broader purpose. Essentially, that you could have a lower cut score if the team that assessed that 3-year-old initially, if they said, okay, instead of using a 24-month age range, we're just going to use a 12-month delay. If they have a 12-month delay, we're going to go ahead and fully assess. And perhaps use of that cut score, even though you might test more, you might be more efficient and better at catching and identifying deficits early on, so you don't miss a child and not provide services for 2 years. So that's also something to consider as you move from student to clinician and practitioner. What kind of clinician are you going to be? Are you going to be the cut score that is the bare minimum? Or are you going to be the cut score that says, I'm going to up it to cast a broader net and catch more fish? So better to serve the fish that I do catch. So going on with standardized testing, and again, I know you cover all of this in another class, so we're just kind of briefly, reliability of test measures the stability of the results. So internal consistency, or the Cronbach's alpha, how consistent is this test whenever you're re-administering it? We want values of 0.9 are great, are good. Values below 0.7 are considered poor, and values between 0.6 and 0.7 are mediocre. So we really are looking for at least 0.8 or above, just like with the sensitivity or specificity when it comes to our reliability measures. And these can be found in the test-retest reliability and how many times you give the test again and again. Did they score the same thing? And the intra-score reliability. Inter-score being that different clinicians scored the same way every time, and intra-score being that the same clinician scores the same test protocol at 2 points in time. So do we keep testing? Do we score the test the same way every time based on what the item is measuring? Then standardized testing, again, brief overview. You really need to understand normal distribution and the effects of that. The normal distribution curve as illustrated on page 111, figure 4.9. Again, standardized tests, they're one component of an overall measure of the child's ability. So you use that in conjunction with criterion reference tests, curriculum-based assessments, conversational speech analysis. An experienced clinician is going to know probably within the first 5 minutes of the conversation if the child's going to be a child with significant language deficits or not, if the deficits are that significant. But you always have those bubble kids, the kids you're just really not sure about. And you need the standardized testing measures in addition to multiple other measures to make that determination. So we use normal distribution of the curve. And in our State Department of Education, again, that's 1.5 standard deviations below the mean, 77 or lower, for a standard score. And the standard scores can be the 100 standard score range. Some tests use the 10 as the scale score range. So 0 to 20 being the total distribution, 10 being the average. But they all function in the same way, and that you have an average, and every deviation above and below is the average range. And I frequently draw this curve for parents when I'm explaining where their child scored on the standard score range, because if I tell them their child scored 75, they're like, 75 out of 100, that's 75%, that's not bad. But if you explain it to them, 100 is the average, 85 to 115 is the average range. So anything below 85 is below average. 75 is at the low end of the below average range. 70 is very below average. You have to explain it into their terms. And I always find visualizations help. In addition to that, you have percentile rankings. Now, these are probably the easiest things for parents to understand. So if you have a percentile rank of 5, 95% of 5-year-olds tested did better than him. If you have 100 5-year-olds tested and they have a percentile rank of 5, 95 kids did better than him on that test. That is a good way to explain standard scores and percentile rankings to parents. Equivalent scores. I strongly encourage you not to use these. These are not reliable. And we love age equivalencies traditionally because you have a 5-year-old and they're at the 2.5-year-old age equivalency range. But they are not well suited to making diagnostic decisions about disorders. I mean, that's just the bottom line. If you have a choice between percentile rankings and standard scores, go with standard scores every time. Percentiles you can put on the parent level, and just don't even use equivalent scores because they're not reliable. And then finally, confidence intervals. We all have good days. We all have bad days. And so one day I'm going to take this test and I'm going to score 95. And tomorrow I might take it and I score 92. And then the next day I take it and I score 98. So 92 to 98 would have been my confidence interval, and 95, 96 being my standard score. So that's the average range for what's happening. And the higher the confidence interval, the more confident you are that that's the range in which the child's performing. So take my example earlier of my 77 standard score kid. If you look at his confidence interval, it was probably 75 to 85. So on a bad day, he's at the low end, but on the good day, he's in the average range. And maybe we just caught him on a bad day. ADHD kid, not on his meds, it's a bad day. It's not a good day to take his test. So those are all factors for consideration when you're doing standardized testing. And then finally, there's this big debate in our field about whether or not language disorder students should be included in the normal distribution sample. So take, for instance, the SELF or the PLS or the OWLS. If they have 100 kids they test, and out of that 100 kids, they include 5 to 10 language disorder students in their sample. Does that change the effectiveness of the test? And that's a debate that if you would like to explore further, I encourage you to read that Pena, Spalding, and Plant article cited. But it does state that the Pena article found that based on their reproduction of test items and their standardization models, that they should not include children with disorders if you want to improve a test sensitivity and specificity. But again, that's kind of one of those theoretical debates. I would like for you to decide yourself. Now, with diagnostics, we always have some potential problems that we need to be aware of. We can have under-identification and over-identification as a problem. We've talked frequently about poverty and SES status, and that that does predict a child's academic performance during the school years. So because those create risk factors, we use the dynamic assessment component and the response to intervention to see if they get adequate instruction, although they come with deficient skills. If we teach them explicitly and directly, can they learn it? And if they can, then they're not a child who necessarily is eligible for IDEA special education. That doesn't mean that the problem's fixed. That doesn't mean that they're at grade level or performing where they should be in comparison to their peers. But their problem's not necessarily due to a disorder as much as it is a deficit based on their cultural, their socioeconomic experiences. And then The next consideration we must have is cultural linguistic diversity. And we must be careful not to equate cultural linguistic diversity with low SES. They are sometimes linked, but not all the time. So those are different measures. So you can have low SES and then cultural linguistic. They speak non-standard American English, such as African American English, is a perfect example in our state that significantly factors into our assessment considerations. So we all bring our own bias into our assessment process. Most of us, according to all the statistics laid out in this manual, are European American women, teachers, or SLPs even, and we know that we're not very diverse when it comes to men in our field either. So we're bringing our own cultural biases into play, so we must raise our cultural competence level. But that requires a conscious effort by a reflective human being who recognizes the difficulty of overcoming bias, because we're all biased to a certain extent. We all can bring our own bias to the table. So there is the risk of over-identification of children from diverse cultures as having disorders, and that is bad practice, but it also violates policy, as I outlined in IDEA 04, that you would be found a violation if you over-identify somebody as a language disorder based on a language difference. On the flip side, if we have established quotas for children in certain racial or ethnic groups, it's not an appropriate solution to say, okay, we're going to hit this quota, and when we hit that incident, that's it. No more kids are coming in. Our state is very guilty of this due to the MATI regulations that are in place for us. The court ruling from the 70s excuse me, that stated that we were over-identifying African American male students. So therefore, that's a consideration oftentimes in special education evaluations, looking at specific learning disabilities. If it's an African American male, how's that going to factor into the numbers that are reported and evaluated and monitored by the State Department and by the federal government? So, but that shouldn't negate the need for services just because you met the quota. If the child is a child who's in need of services, it shouldn't matter their racial or ethnic background. So reduced access to assessment and intervention services should not become the default approach to avoiding test bias and disproportionality. But we know that students from culturally linguistically diverse backgrounds and low SES don't have that access to early interventions as much as a parent who might be more informed. Hence the prevention presentations that y'all were doing, and this week's that was very appropriate in targeting those low-income young mothers. They might not know that their child is exhibiting deficits. They might not have access to early services because they're not necessarily going to the physician for their well visits. They only go when the child's sick or to get the mandated shots. And if they get the mandated shots, maybe going to a health clinic who doesn't spend a lot of time talking to the student or child and really assessing what that child's ability is. Now, there are a lot of great services out there, and there are physicians and other providers referring children to those services when they have access to them. But we don't necessarily have access to them until the general education time when they come to school, because that's required for them to come to school. I can't tell you how many times I've had a 5-year-old come on the first day of kindergarten with no preschool experience, no background, and mama just kept them home the entire time, and their language and their speech was so deficient that they were at least 3 years behind their peers. So that's a great hill to climb. And oftentimes we can't completely reach the top, as we discuss in the prognosis piece next, but we need to have better accessibility to those populations to get them access to the services. And finally, dual language learners and English language learners. Not only is it best practice, but IDEA does mandate that we must assess them in their native language. We can use RTI to better ascertain whether or not it's truly a difference or a disorder. It states the research found that these English language learners, dual language learners, acquire skills quickly when given explicit instruction and early reading. So if they're taught it, they usually learn it. It's the ones that you teach and they don't learn it despite effective instruction that you should be concerned with. One of my ELL clients early on in my experience was a child. Let's just say her name was Sarah Silverman. And it was a alliteration, first name beginning with S and last name beginning with S. But she was from a Hindu, Asian Indian family, and she had the T for S substitution. And so we had to ascertain whether or not that error was an error in her native language or just a dialectical error. But of course, if the father and the brother and other familial people around her could say that S production because her name, Sarah Silverman, was with the S, it wasn't because it wasn't a sound or phoneme occurring in her language. She had a phonological processing error. So those are always factors to consider. And you can rule children eligible, but you just need to make sure that you're evaluating how it's occurring in their natural language. Okay. And then the last portion of this chapter is prevalence and prevention and prognosis. So prevalence is the total number of cases with a particular disorder in a certain time period. The incidence is the total number of new cases of a disorder in a certain time frame. The table in 4.3 gives you some prevalence numbers for the populations that we serve based on the national data. Now, it is important to note that this data tracking system only accounts for primary disabilities. So students, for example, those 260,000 plus students receiving services for a developmental delay from ages 3 to 5, in addition, might also receive services for a speech or language impairment, but they're not counted in speech or language because they receive it under developmental delay. And the same goes for any of those other disabilities. And the author points out about the change in numbers from 900,000, almost 1 million students receiving speech or language services ages 6 to 11 drastically reduces from age 12 to 17, whereas the number of specific learning disabilities drastically increases. So more than likely they can morph into that specific learning disability or expression or listening comprehension if their language disorders are that significant. So, and I've had many students who start off language speech only, and by the end of first grade, beginning of second grade, are ruled with a specific learning disability. I continue my services to them as a related service, but they're not counted in those national statistics. But it's often stated, and I think fairly accurately, that more children are served for language speech impairments than any other disability. And although that these numbers don't match for the total, when you look at table 4.3, then it's probably more accurate when you consider the related services that we provide to other disabilities such as developmental delays, SLD, and autism spectrum disorders. So we have the different prevention methods that we can use to try to prevent the incidence of the disorders. Primary prevention reduces new occurrences of disorders. Excuse me, but the book didn't really discuss that very much. We will discuss that a little bit later in chapter 6 about the seeming increase in autism spectrum disorders, but we'll table that for a later discussion. Secondary prevention is like what you did with the prevention project with group 1 of early identification of a disorder to minimize long-term effects. We know if we get them at age 3 and we can resolve the issues by age 6, they'll have a better long-term prognosis. So secondary prevention is very important. And then the tertiary prevention, which is activities aimed at remediating current problems after they have appeared, such as the IEP process after we've already done eligibility. And finally, prognosis. This is a prediction about effect a condition has on developmental outcome. But prognosis is very difficult to make. And I've had parents ask me, the causes of our of language disorders and the prognosis. How bad is it? How long is it going to take to fix it? And of course, I always have to say, I really can't say. Every child's individual, and you can cite the student's strengths and things they have working for them in order to indicate that their prognosis is good. We never want them to think the prognosis is bad or deflating, because then you have the element of the self-fulfilling prophecy. Expectations influence the degree and direction of change, also known as the Pygmalion effect, the Rosenthal effect, the Hawthorne effect, the placebo effect. Depending on the expectations you set, it will factor into the performance. So if you think every child you treat is going to have better language and speech skills at the end of your treatment, then they will show that and they will show growth. But if you assume that that child doesn't have the ability to master the goals and objectives that you're doing, then you're setting them up for failure before even beginning your treatment. Excuse me. Then finally, we have protective factors associated with the disorders. One being the disorder type, language impairment. A language impairment with a higher cognitive ability has a better prognosis than a language impairment with a low cognitive ability, and that's just the nature of the disorder. You also have personal resilience. We have personal friends who have a child who had a diagnosis of mild CP, not really a full-blown CP, so there's no official diagnosis that's a special education eligibility, but there are different motor limitations related to hypertension in the muscles that have never been enough to warrant occupational or physical therapy services, but the parents have been given strategies and exercises to do with the child to make the performance better. And this is a child, the natural athletic ability isn't necessarily there, but the personal resilience is so strong that after a year of gymnastics, her cartwheel is pristine. It's perfect. And despite all those motor and physical limitations she had, she was able to overcome that due to her personal resilience. Is very much in her personality. So that's a definite factor in our prognosis of treatment for disorders. And then finally, educational and intervention resources. How much access do they have to good quality resources? And it states that people or parents that are involved who and felt confident about facilitating communication with their children, this was with hearing impaired children, had better results than the parents who weren't involved. And so if you have access to the education and intervention resources, you're going to have a better prognosis, and the parents are going to be able to be more effective in increasing the prognosis for their children. So it is our job to share prognostic information with parents, but it's also our job to say that much of it's unknown because of the nature of humans and that we're all different and everything's individualized. We can't say for sure how your child's going to do or respond to therapy, but we can say that we're going to take every effort that we can to make them better and give them the skills they need in order to be successful in whatever their potential is, whether it's educational or vocational or social. And then you also have to be wary of any false methods, substantiated claims of miracle cures, and I've had a lot of experience with this, and sometimes you just say that you really hope that it works out well for them, and in the meantime, this is what I'm going to do to enhance your child's instruction and your child's skills, and we will do everything it takes to make your child more successful. And we will support them however we can, but providing parents with outside sources, outside research is also very helpful because we can't help it. We all want a miracle cure. And we should know as a clinicians that anything that seems too good to be true probably is. And we need to be wary of those and how to manage those personal relationships with parents and others who might latch on to those miracle cures because it sounds so good to be able to fix their children. And generally, again, we're not going to be able to fix all these problems. We can remediate, we can give them strategies, but we cannot fix everything, and we need to be very forthcoming about that.